sex and gender in medicine is really a very topical topic in that National Geographic had a whole issue on gender. Not exactly the way we've been talking about gender, but it's all part of the same conversation as far as I'm concerned. Time Magazine had a whole issue on it. The Stanford Medicine had, the spring version was all about sex and gender in medicine. And what we passed around for you is an article that I wrote in, for the Scientific American issue that's called It's Not a Women's Issue. And the whole issue is about sex and gender, so I only had access to the one article, and that's what you have. You heard about this earlier, the 60 minutes, well, actually the issue about Ambien, Zolpidem. This got a lot of press, and it really had a big impact on people becoming aware of the fact that we do think that sex matters. So this was a 60 Minutes episode. As you probably realize, insomnia is much more common in women. So 6 million women were using this drug, and compared to 3 million men. And what they found was that they changed the dose because 15% of women and 3% of men were having trouble driving after they took the Zolpidem. And what you see here, oh yeah, here's the pointer. These are Cohen's D's, and a large Cohen D is 0.8. Anything above that's even larger. So the difference between men and women on clearing this drug is a really high difference. And so you can see that there's only 29% overlap in terms of all the men that were studied and all the women. And the women were clearing it in a really fast way, but much, much later than the men. And the consequence is that the driving impairment was much higher in the women, also a large Cohen D compared to the men. So that got a lot of attention, and as far as I know, this is still the only drug that has sex-specific labeling. Now, in fact, because 3% of men probably should be on the 5 milligram dose, then people really need to be thinking about the more than just the sex. And so this is where when we start to talk about precision, we have to realize that there are men who are falling in these categories as well as women in the other. Back in 2009, Irv Zucker, who's a colleague up in Berkeley, published this really important paper with his postdoc, Barry, first of all, looking at what % of non-human research used only male or female, so the only males in blue, the only females in red, versus did we know anything about it, and then both is purple. So the ideal would be purple. Oops, I didn't mean to put that on there just yet. The ideal would be purple, and what you see is that in certain fields, so certain disciplines like general biology, immunology, neuroscience, we don't even know the sex of the cell, of the animals, and then you can see that there really is not this attempt to look at both groups. And then other areas are really predominantly male, and only 26% of these studies were reporting on both sexes. It's a little better in human research at that time. 60% were reporting on it, so there's a lot more purple. In the one area of reproduction is the one place where we study females. So almost all women's health for a long time, we called it bikini biology because we were just focusing on the unique things instead of looking at all the rest of what women were. And then when we had this recognition that these drug trials, which Dr. Clayton referred to before, we recognized that there was a lot of bias in not having studied females. And I will tell you the Zolpidem story was really interesting because I went back to look at the literature, and they already had seen in rats or mice, I can't remember which rodent it was, a big sex difference, and yet it went forward. So this wasn't even a case of not doing it, it was a case of not paying attention to it and letting that go to market. You already saw this proceedings, and now we actually got to hear from someone who was on it. This was really a landmark paper, or a landmark book, that basically looked at whether sex does matter as a biological quality or classification in terms of do we need to be looking at this. And the conclusion was that every cell has sex, and yet we don't have very many cell biologists who know the sex of their cells. They also define gender as the sociocultural factors. So this is where I first became aware of it, but now I know it was way back before that. And in that particular document, they homed in on gender identities, how individuals perceive or present themselves. But when we really talk about gender from the perspective that you'll hear in much more detail from Londa Schiebinger, we have to be looking at gender norms. These are affecting us very much in all of our different cultures. And so we can be the individual in the middle, but we're getting a lot of things coming at us that are going to influence our biology and gender relations. We're going to be interacting with people in ways that all affect our biology. So to have these as being completely separate entities is really not appropriate for humans, because we are an integration of all of the culture that's coming at us. So you've heard what sex and gender are. I'm just going to go through this really quickly. We get assigned at birth. You can make a lot of wrong assignments, which there are plenty of cases of people that don't have the internal genitalia or the external genitalia that really matches other things, but it relates to your identity to some extent. But this is how we define sex. And so it is largely because of the chromosomes. There are variations, as you heard about. We could have XXY females sometimes, XY. You could have all the combinations, but generally, most females are XX, most males are XY. And the consequence is that it's going to change the indifferent gonad to be either a testes or an ovary. And it also is affecting the brain in terms of the neuroendocrine regulation. So some things happen in utero that are going to determine how you're going to actually be getting your feedback between your hypothalamus and your pituitary and your gonads. Another point that was made is there is a big sex difference then that's going to happen, not just because of the hormones. We have a lot more sex. We have a lot of work in the autosomes to do to figure out what are these differences. But the hormones actually do affect the bones in a major way. And testosterone has a tendency to make the bones, it grows on the outside of the bone, and estrogen takes care of growing on the inside of the bone. So you end up with slenderer bones for females and thicker bones for males. So when we just talk about bone mineral density, it isn't just a matter of density. The engineering principle of the bone is different. So if you know about how diameters work, if you have a bigger diameter, you have a more solid structure. So there's a lot more than just bone mineral density, which everybody focuses on in terms of the structure. And this may be something that's on the autosomes as well. But it does result in a pretty big sex difference in terms of height with a fair amount of overlap. And I don't have the Co and D on there, but it's a pretty, there is some overlap, but it's not as much as you might think. One area that I think we could really do a lot of work on is the pelvis. The genetic pressures, the evolutionary pressures on the pelvis are so strong that there's a really big sexual dimorphism in the pelvis. For the female, if she doesn't have a wide enough pelvis and she's trying to deliver a head that's too big, she's dead. And that happens in a lot of places in the world. Whereas when we talk about what's the ideal pelvis for locomotion, it would be a narrower pelvis. And so we have a lot of pressures trying to keep the pelvis narrow or trying to get the pelvis wide, depending on that sex difference. This would be a great place to look at autosomes and figure out what's really going on there. Once we start to talk about putting on body fat, that's largely hormonal, but I think that we have a big ways to go to find out what are the genetics of this as well. But we do know that when people start taking hormones of the other sex, they start to redistribute their fat, and certainly when women go through menopause, they redistribute their fat. Body composition has a lot of sexual differences, but we're going to talk about that later. So gender, I have no idea what those genitalia are under that outfit, so I can basically be whatever I want to be just fine, and you don't have to worry about how I was assigned. That said, we have lots of cultural pressures to dress differently, behave differently, and do all of these things differently that might in fact affect our biology as well. And here's a great example. The imperial Chinese foot binding, which began in the 10th century and went on for 1,000 years, was really designed to make the beautiful woman, her foot was what was beautiful. And what you can see here is that this foot, this is what the biology should have been, and this is what you can do by having a gender pressure on the foot, so it was important to have the most tiny feet you could. That was a sign of being beautiful. And I will say that we haven't come completely away from this at this point. So we still have a lot of gender issues in terms of our dress that may or may not be that healthy for us. So I do want to say a few things about women specific. So when we talk about the lifespan, there are things that are truly unique to the women besides just the X inactivation issue. A big part of what makes us different is our reproductive issues. And so we have all of these phases, these life phases, when a lot of dramatic things happen at these life phases. So I've been doing life course research forever. And I will mention that men also, of course, go through puberty. But the consequence of that is a little bit different, and we'll talk about that as we move on. But all of these phases are really unique phases. And I can tell you when people talk about sex differences, they often say men and women. It's like, well, is it a pubertal male, pubertal female? Is it a pregnant woman? Is it a middle-aged woman? Is it a postmenopausal woman? Women are as different from each other themselves as they might be between men. And so this is something else that I think we need to get on our radar screen. And of course, older adults. I keep changing this upper age here, by the way, so I used to have one of these numbers there, but we've got rid of that. Okay, so we heard a lot of great stuff. That was really fantastic about the X chromosome. And what I just wanted to do is kind of bring into this discussion when this inactivation happens and how profound it is on the organism. So we could have our paternal or our maternal X coming from either our paternal or maternal. You can go through all the different family trees here, but here we're going to have a sperm meet up with, so the sperm has made its way up here, it's going to meet up with this egg, immediately divisions start to happen. So there's a lot of stuff that happened before this even implants. So it finally implants, and by the time it implants, we have a lot of cell clones. And so when we talk about this inactivation, this is happening really early on in the developmental process before we have organs. We basically have clones that are going to turn into organs, and so every tissue in your body is a mosaic if you're a female. And so we talk about females are mosaics. Identical girls are not as identical twin boys for the reasons that we heard in the previous discussion. But this mosaicism is something to remember when you start to talk about sex-linked characteristics. So just to kind of orient you, we always use the calico cat as the example. The calico cat's almost always a female because it's a matter of X inactivation of the clones that are going to make these color patches. But some of the examples that everybody knows is colorblind people are usually males. Now, it's only true of the red-green receptors because the blue receptor is not on one of the X chromosomes. But this is a random process, so many men in our population can't see the 29 and the 45, and if you can't, then maybe you're colorblind. But at any rate, this is something that is because of the inactivation process. Females have two X's, and so they can compensate for the one that's defective. Now, there's actually two variations of the red receptor, by the way, so there's about 3 to 4% of women in the population that they claim see super red, so they actually have two wavelengths for the reds. The other one that's really well known is hemophilia. Queen Victoria was the carrier, so they call it the royal family problem. Her son died at age 30. She had 2 daughters that passed it on to 9 males, and none of the females were affected. So this is another place of sex differences, but then just to remember that on the retina, you've got this mosaic, and so that's why you still can have some of the cells are just seeing fine, and some of the cells aren't. We heard about this as well. So this is really the preconception issue. Doesn't include the epigenetic part that we talked about. But just to be aware, the placenta is part of that whole process that is dividing early on, that is becoming the embryo. It's made up of the fetal cells. The placenta has sex. So it's either XX or XY. And there's a lot of information coming down the pike now that these placenta function differently. They have different strategies for dealing with assaults that are coming at them. And the data that are accruing, and actually we have a great project here, Virginia Wynn and Amy Braun are doing this work, that we have evidence that for the male, the placenta is adjusting the gene and the way this reads out so that it's really focusing on growth, that being larger is the important thing for the male embryo. The placenta is protecting that. This is a hypothesis still, it's being worked out, but that for the female, there's other things that are happening in this process. So they're not focusing on growth, they're focusing on survival and other factors. And this is basically in response to a stress that the mother experiences, the placenta will actually function differently. And one of the potential consequences of this are neurodevelopmental disorders that we do talk about as being, and know, are more common in boys. That said, I will say that there's a lot of diagnostic biases, so we're learning more and more about that here at Stanford. We have people working on autism, and we know that the way girls are behaving and boys are behaving is seen differently, so it's diagnosed differently, but it does still seem that there is neurodevelopmental disorders, including dyslexia, stuttering, and Tourette, that may relate to these different placental strategies. When we talk about some of the female-biased neuroscience issues, anorexia, bulimia, PTSD, anxiety, depression are ones that we often talk about. We know that this is true worldwide, that women are more depressed than men. And many people say, well, okay, this starts really in a big way through puberty. There's evidence that it depends on if you go through puberty with your age mates versus if you're early girls who go through puberty earlier are more likely to be depressed and have eating disorders than girls that go through in the middle. Those that are going late, it's just kind of like there's pressure because you're not like your peers. Before I show the next piece of this, I just want to make the point that what's happening along the way is menstruation, and you actually start to become reproductively capable. And certainly males are having that same issue. But something that I think is really interesting, and I teach a class on the health impact of sexual assault, is that we have to realize that when girls start to look like women, they now are getting sexually assaulted, they're being treated differently, and we can't just say that because it's bad at puberty, that's the evidence that it's hormones. The hormones certainly have an indirect effect, but I think that we have to look at these peaks. This peak, by the way, is largely males, so they get a much younger sexual assault before they go through puberty, and this peak is mostly females. And so we have some really big sex differences in when we're being exposed to what I'm just going to refer to as ACEs, the adverse child experiences. We know these are strongly related to negative outcomes. I'm just going to throw this up really quickly. These adverse child experiences are things that we have to factor into everything we do with psychology and with neuroscience with humans. We have to take this into account. Now, this original study was done back in the 90s by the CDC, Kaiser Permanente did it together, showed that the more of these assaults you have, and they include not just sexual assault, but physical abuse, emotional abuse, having an alcoholic parent, having someone with mental health issues. So there's a lot of different things that will add up to these ACEs. But just so you know, the CDC is continuing to do this. They're actually doing it in DC and in 10 of the states in the United States, and they do have gender, race, age, and what you can't see is education because it fell off the slide. But there's a lot of great data there that we should be going after to find out, how can we tease apart things that we've been attributing to pubertal and hormonal things when in fact these are very much gender issues. And another one that I just want to mention is sexual health. There's lots of different values in all of these different cultures. There are different norms, but I think a norm that's pretty evident in our society is that we talk less now, but certainly when I was coming through puberty, about we have good girls and bad girls. And that really comes with a lot of psychological baggage, and it's stuff that really does affect you. If you are sexually assaulted, you are shamed, and that shame has a huge role to play in your ability to heal or not to heal from that episode. That's gender. And so those are things that we have to kind of keep playing into our whole thinking about this process. So I think that we live in a sex-negative culture by and large, and I'll just say that many of the things that women go through is also very true in the LGBT community, and so these are areas where we just need to keep remembering that society is affecting us because of our gender norms. I think most people in this room know that we have the ability initially. I don't know now that I've seen the AutoZone, I'd really like to know. what kind of other changes there are there besides the gonadal hormones. But we have bipotential gonads, I think. I always thought of them as bipotential, but I'm reconsidering now after that last talk. But generally, we have the ability to develop either male organs or female organs. And up until the last talk, I would say that I think that everybody in this room had that potential. So we had that potential, and then after you get the gonads going and you get some of the fetal testosterone in particular, everybody's bathed with estrogen from the pregnant mother, then we're going to get male or female genitalia. And if that all works out right, you're going to get assigned in the way that fits your reproductive capability, but we still have all those other organs that are doing other things, and we never pay attention to that. The only one that I'm going to talk about, because there are lots of examples of things that happen, is the androgen insensitivity syndrome, where this is an XY individual who's insensitive to this testosterone, to this testosterone, and so their development is very different. They have female external genitalia at birth. The vagina is actually shallow, but nobody really does a gynecological exam when you're born, so you don't really find out about that potentially until you're not menstruating. Internally, there are testes that are producing huge amounts of testosterone that's converted to estrogen in the body. There are no male ducts because the testes is giving off a hormone that you are responding to, the anti-Müllerian hormone, and you have no ovaries or uterus, so you basically can have multiple forms because we have a range of this insensitivity. So this is another area we could look at how sensitive are these receptors to the hormone that would actually let that genome express itself in some other way. But these are both cases of androgen insensitivity. And just to make the point, now I have a lot more question after the last talk, but this is basically an XY and an XX chromosomal pattern where we have 22 autosomes that have a lot of stuff going on. Now I know there's some sex differences in those autosomes, but the reason why I want to say that is most of what you are is on those autosomes, and then something of what's really important to you, but almost all of us, so for the precision thing, most of us have really strong gender identities. Even if our gender identity is I'm not male or female, I'm something in the middle, you have a strong feeling about that, even though 22 autosomes are going to predict what you're going to be independent of being male and female. And this is an example. So we have really stereotypic ideas of what bodies look like. We pretty much have a society that thinks that this is what the man is, and that unfortunately this doesn't look like a woman because it's me, but we have an idea that women are going to be more like that or like this. And what this is showing, these are called somatotypes, and this is based on your autosomal qualities. So depending on what hormones you have, you're going to get more muscle or more fat, but on top of what you already would have been based on the 22 autosomes. These are all Olympic athletes who are at the peak of their athletic performance. So these are elite athletes who basically have lots of body shapes, and every one of them has a body shape or body composition that's appropriate to the sport. They basically, you select your sport based on what you're capable and able to excel at. But a point to make is that, you know, this is the right shape for this woman. This is the right shape for this woman. She's a gold medalist weightlifter. And that's what she is. She's an endomorph, and she is as fit as she's going to be, and she's basically developed her potential. So we have a lot of biases about what people are without really understanding enough about their body composition. And I'll just say, standing on the bathroom scale doesn't tell you if you lost fat weight or lean weight, and what you want to be losing is fat weight. So here's another example of these are identical twins. I don't understand how this would actually happen if things were so biological, but Wyatt decided that she would like to be Nicole, and Jonas said, well, I'm happy being Jonas. And so Nicole got puberty blockers, which is basically something that we have a pediatric endocrine clinic here at Stanford that will help children that don't want to go through those radical changes that you go through puberty until you had a little time to think about, what do I really want to come out here? here on the other end. And so these are basically Nicole and Jonas. Nicole is living her life as a female, and Jonas is living his life as a male. So there are some identical twins that we might be able to get some information from, but the bottom line is it gives us a lot of sense of what is happening with just the hormonal manipulation. I'm just going to quickly mention that when we talk about what is a woman and what is a man, it's just not as binary as we talk about, including people who really do relate to being a female. So if we actually look at sports, this is a place where, because sports is going to emphasize someone who's going to be more physically active and maybe potentially more muscular, so there may be other things that will go into your gender idea there. But in the 1900s, the women started participating in the Olympics. The females had to parade nude in front of doctors to be sure that they were females. There was a really interesting set of cases in the 32 and 36 Olympics where in the 36, Helen Stevens won, and Stella Walsh, who had won the year before, said, "That's not a woman, that's a man." And it actually turned out they paraded her nude, and she looked like a woman based on that. But it was Walsh who was, it was an accident that she was shot early, but they did an autopsy, and she actually had male genitalia, but didn't know it. She had internal organs, and it turns out she was a mosaic. So some people are both male and female. And then they started doing mandatory testing. It went through a phase where I think many of us remember that all of a sudden we thought that these Soviet Union people were males, but they were females. They didn't know it. They were giving vitamins that turned out to be testosterone. But part of this consensus conference was also the fact that there are women with naturally high androgen levels. That's what they do. And so are they not a woman because their testosterone levels are high? How do we even define these things? So this is just trying to say we have a lot more spectrum in the biology. It's not just the gender. I think that we have a lot of range to play, even though things might stack up pretty strongly on two ends. There's a lot going on in the middle. To just make a transition to the health part of this, if you're this is the Lifecourse model, again, for females going through that same phase. And this is talking about what % of deaths occur in these different categories. And then just to throw, of course, not all women get pregnant. If you do get pregnant, it has some real biological consequences that we're going to talk about. But I do want to just point out when we talk about males that in every one of these 20-year places, twice as many men are dying, are boys, twice as many men. It starts to get off a little bit here just because of survivor problems. There aren't as many there. But an interesting point is that when we talk about old age, if we're going to call it 80, soon I'll call it 85, but at any rate, if we call it 80, 53% of women make it to 80. Only 35% of men do in this country. So geriatrics is a women's health issue. But what are those issues? And we're going to hear about this in the next talk. But at any rate, men are just going along with their reproductive years until maybe they have andropause. Andy Hoffman, who's here, could talk more about that than I can. I'm not going to go through this whole thing because I don't have time, but just to make the point that there are differences that we can start to really drill into, like what is happening when that knocks off the boys at earlier ages. Certainly accidents is a big thing. I actually do a whole class on this, sex and gender and human physiology disease, where we go through these time frames. But what I want to do is just kind of point out the leading cause of death in women is heart disease. And we heard about this before. Women have a very different, not very different. Older women are pretty similar to older men. But young women have very different symptoms. And the problem that we've been dealing with for several decades now is trying to train women to say, chest pain, if I do chest pain, I might get that CPR, I might get the balloon, I might get something. But if I start telling you, oh, I have neck pain and jaw pain, and I'm dizzy and I'm tired and all these things, then that distracts the physician. So we should train the physicians, but we also need to train the women so that they just say something that's going to get the immediate attention of somebody. But we're very aware that there are these differences. And a lot of work has gone in the world of cardiovascular disease. So the WISE study, which was the Women Ischemic Syndrome evaluation, was really kind of the study that demonstrated that we really do have some different pathology of these younger women that are reporting these heart disease. In particular, when we talk about obstructive atherosclerosis, which is the most common thing we hear about, you put a catheter in there, you see there's a blockage, you can follow the pressure wave, you see a drop in the pressure, ischemia is going to happen right there. But when they go into these young women, they very often don't find any blockage because the entire artery is sheathed with this plaque. And so you don't see a spot like that, but the pressure is falling very gradually, and in the end, you have ischemia just the same as on this end. So these are things that are really biological differences that we do now know about. At Stanford, we do. I don't know that everybody in this country does. And we've already talked about the fact that pregnancy is a cardiovascular stress test. If you've ever looked at the physiology of pregnancy, it's very profound. For a body to be able to go through that, you better have different blood clotting factors because you may have to clot. There's a whole bunch of things that explain our biology based on our reproductive issues and the fact that there's a lot of evolutionary pressure for this. But this is definitely a stress test. And if you end up getting preeclampsia or hypertension or gestational diabetes, you have an added risk factor. Now, it may be that that risk factor was already there, and that's why you got the hypertension or the preeclampsia, and it just manifests itself, or maybe that actually precipitates it. We don't know which came first. We only know there's a really high correlation and that we should be looking at women's risk factors with that in mind. And the only other thing I'm going to say on this one is that, in addition, while you're pregnant, there are cells that are shed both from the fetus to the mother and from the mother to the fetus, so that women actually have some cells from their offspring, from their children, still floating around. They see it like 30, 40 years later. These are stem cells that are, I don't quite figure out where they are, but we have lots of evidence. And people started to think that this might be related to the autoimmune disease issue, but it didn't pan out for all of them. May relate to some of the cancer issues. And just to say something about cancer, the interesting thing, so it came up earlier, if you're not aware, men die of cancer and men get cancer at much higher rates than women do. And it's true for almost all cancers, with the exception of thyroid cancer, where women get it more often but die at similar rates, and anal cancer, and there's one other one. But these are the ratios. So all cancers, 20% more likely to get any cancer if you're a man versus a woman, 40% more likely to die. Lung cancer, this could be gender, very much a gender issue, because smoking might be responsible. Colorectal cancer, we have sex differences. Women tend to get their colorectal cancers in the ascending limb. You're not going to pick that up with a sigmoidoscopy. So you have to realize that we do need to be thinking about some of these things that could be biology, could be diet. So women eat differently than men do, by and large. Men think that you have to have meat because you're big and muscular, and it's not always true. So I'm saying a few generalizations, and forgive me on that, but I could also show you the data to support it. And you can just see all of these cancers are higher in males than in females. So and when you start to look at disparities, health disparities, sex is the biggest health disparity there is, sex and gender. Males are... you're going to hear it in the next talk, so I will let Mark talk about that. And by the way, this cancer incidence and death issue is true in every race, ethnic culture in the United States. So this is showing you that in every race, ethnic group, men get more cancers, and they die more often from cancers than women do. So this is a big, interesting thing, and we can look at all the genes that we want to with precision medicine, but we could just ask, is it a male or a female, and should we treat them differently? So I mentioned the autoimmune diseases, and it's been spoken of. Lonnie, you're my timekeeper, so. Okay, so this is just to show you that within each age group, this is the 50% mark. So anything above that is where females predominate over males. And there are certain autoimmune diseases that express themselves before puberty at higher rates. There are some that are really in the perimenopausal time, and there are some that are really come up in the postmenopausal time. So there's lots of evidence that hormones do play a role. This is asthma, where it's really high until boys go through puberty, rises at puberty in girls. But there's lots of other factors besides the hormones that we should look at. To kind of say a few more things that are really different between men and women, certainly the fact that women are born with all the eggs they're ever going to have, and it's all downhill from there. You're going to lose them. Males don't really start going through that next step until puberty. So these are very, very different issues that must have a lot of autosomal reasons or other reasons for it. But the consequence of this for the females is that here are the follicles. These are the follicles that could be developing, dropping really rapidly. And to make the point that females, the follicle that's ovulated is, and the cells around it, are the source of the estrogen. So as these follicles drop, estrogen levels drop. That's not true. In men, the two processes are separated. They're interacting in important ways, but the sperm are not making the testosterone. In the case of women, the follicles are making the estrogen. So it's a pretty profound difference and does result in lots of physiological changes, which men will experience if they have prostate cancer and they get treated with anti-prostate cancer, with anti-hormones. But the menopausal phenomenon is something that is really unique to women unless you're talking about treatment. In the time that I have, which isn't much, I'll just say that the next one I just want to mention really quickly is neuroscience, and to make the point that there's a lot of interest in sex differences in the brain. And people love to make jokes about it, like everything about it, and they haven't really looked at it often in the scientific way that we need. So there have been various consensus conferences. One was on pain that basically showed that women actually have a lower pain threshold, so they experience pain at higher rates than men. Everybody believes the opposite because they think, oh, you went through childbirth. Well, that was maybe a 12-hour, maybe 24-hour problem, but it's not like every day, and so it's not true. But to just kind of go through this men are from Mars and women are from Venus concept, many people still joke about this, talk about all the anatomical differences between men and female brains. And if we actually look at the Cohen's factor, it is a very big difference in brain volume between men who have larger brains than females. And so we can recognize that issue. But this is hippocampal volume differs a bit. But to just kind of normalize this by here's your height difference, which is this huge Cohen's D, 1.97, so only 32% overlap, with brain volume. If you adjust that, you actually see that the brains are really quite similar for the size of the person. Almost none of the neuroscience studies take this into account. It's really a problem. And this is the last one that I'm going to kind of mention is this got a lot of press, this idea that men's brains, so this was a connectivity study where they were looking and saying that men's brains are wired within the hemisphere and women's brains are wired across the hemisphere. And then they concluded that this explains all these other things. It explains, why this will facilitate communication, analytical, intuitive processing. The question I've asked when I see this is, do the data justify it? Let me see your data. So this turns out to be a huge overlap area. That Cohen's D is moderate, small to moderate. It's certainly not evidence that men are like this and women are like that. It's evidence that men and women are pretty similar, and there are some differences. But those differences may or may not be biology. There could be gender things that make those differences. I don't think we really have the answer to that. And so to kind of just end, I'll say the last big area that I want to mention, there's many, many more areas, is the other neurological difference is aging. Women are much more likely to have Alzheimer's disease. And there are lots of reasons that may be responsible for this, that may be genetic, may be in our X and Ys. But one thing I do want to just kind of end with is, in addition to all these other things, women are the caregivers in this society. We are kind of like not all women, there's many women that are caregivers, but this is something that's another huge burden, and it's an area where I think that we need to pay some attention to who's getting Alzheimer's, but who's treating the Alzheimer's patients, who's treating all these other people. So that's why I think sex and gender do matter in precision health. Thank you.